Two patients, same week, same diagnosis. One walked out with a treatment plan and a follow-up appointment. The other walked out with a prescription she could not afford and no way back to see me again. Day 28. 2 days left in this journey. And today I want to describe something I have witnessed repeatedly across a decade of practicing medicine in 2 countries. What healthcare inequality actually looks like up close inside a single examination room, not as a policy statistic. As 2 human beings, identical diagnoses, completely different outcomes, determined almost entirely by what was in their bank account, not what was wrong with their bodies. What I have seen from both sides. I have practiced medicine in private clinics, in public health units, and now in a direct primary care model that sits somewhere in between. I have treated patients who could afford every specialist referral, every advanced diagnostic test, every brand name medication without a second thought. I have treated patients for whom a single ultrasound represented a genuine financial sacrifice, money that might otherwise have gone toward food, rent, or a child's school fees. The clinical knowledge required to treat both patients was identical. The actual outcomes were frequently not. The wealthier patient who needed physical therapy after a hip fracture received it, recovered well, and returned to full mobility. The patient without that financial cushion delayed the physical therapy, developed complications from prolonged immobility, and experienced a recovery that took months longer and never fully reached the same functional outcome. Same fracture, same surgical repair, same medical knowledge applied. Completely different lives on the other side of that diagnosis because of money, not medicine. The mechanisms of inequality I witness daily. Let me name the specific mechanisms through which wealth determines health outcomes, because the pattern is consistent and predictable, even when each individual story feels unique. Delayed presentation. Patients without financial security frequently delay seeking care until a condition has progressed significantly, not from ignorance, but because taking time off unpaid work, paying for transport, and affording the consultation itself requires resources they are rationing carefully. By the time I see them, what could have been a straightforward early intervention has become a more complex, more expensive, and more dangerous clinical situation. Treatment abandonment. I have prescribed identical medication regimens to patients of different economic circumstances and watched the wealthier patient complete the full course while the patient under financial strain stops the medication early, sometimes to save money for other expenses, sometimes because they could not afford the follow-up visit required to get a refill. Diagnostic delay, the ultrasound, the blood panel, the specialist referral that could clarify a diagnosis within days for one patient takes weeks or months for another patient navigating the public system's queue, or simply does not happen at all because the out-of-pocket cost is prohibitive. Nutritional and environmental disadvantage. Even when treatment access is similar, recovery is not, because adequate nutrition, safe housing, clean water, and a stable environment for healing are themselves distributed unequally along economic lines. Why this is not simply an argument for charity. I want to be precise about something important here The solution to what I am describing is not simply asking wealthy people or wealthy nations to donate more generously to poor patients or poor countries. Charity treats inequality as an unfortunate but permanent feature of the world that requires periodic generosity to soften. What I am describing requires something more structural. It requires health financing systems designed so that the ability to pay does not determine the speed or quality of care received. It requires primary care models like direct primary care that can offer affordable, predictable membership pricing rather than unpredictable fee-for-service costs that punish patients for needing care at the wrong financial moment. It requires policy that treats healthcare access as infrastructure, the way roads and electricity are treated, rather than as a market commodity priced according to what the wealthiest patients are willing to pay. This is the deeper reason I have built my professional life around direct primary care advocacy rather than charitable medical missions alone. Charitable missions treat symptoms of inequality. Structural reform addresses the actual disease. What I am asking of every health professional watching this: if you are a doctor, a nurse, a health policy professional, or a health entrepreneur watching this, I want to ask you to examine something honestly. Every clinical decision you make happens inside an economic system that either narrows or widens the gap I have just described. When you price your services, are you pricing them in a way that preserves access for the patients who need you most, or only for the patients who can pay the most? When you design a health program or a clinical protocol, are you designing it with the assumption that every patient has reliable transport, stable income, and flexible work hours? Or are you designing it for the actual economic reality of the population you serve? When you advocate for health policy, are you advocating only for incremental improvements within an unequal system? Or are you willing to advocate for the structural changes that would actually close the gap? I do not have a complete answer to healthcare inequality. No single doctor, no single practice, no single policy reform will solve something this deeply embedded in economic and political systems. But I refuse to practice medicine as though the wealth of my patients is irrelevant to their health outcomes, because every year of clinical practice has shown me repeatedly that it is not irrelevant. It is often the single most predictive factor in the room. If this named something you have witnessed in your own clinical or professional experience, share it with a colleague who needs to hear this perspective. One day left after this, day 29 tomorrow, the Global Health Architect Manifesto. Everything I believe in one final video. Subscribe. Comment below. Have you witnessed healthcare inequality up close in your own practice or community? What did it look like?